So you can go ahead and get started.
You're closer. Try here.
I'm not sure what's happened with their mic. We're still seeing. So we'll try to attempt to fix that. But you can go ahead and get started, Mr. Mayor.
Okay, thank you very much. Welcome, everyone. My name is Dan O'Neill. I'm the mayor of the city of Edmond, and this meeting for Monday, August 17th, now called to order. This is a city council workshop for the city of Edmond, and we're conducting a joint meeting with the Oklahoma City County Health Department. This will be a video conference only. I want to thank you all for joining us.
What is that? Callie Reeves.
We made a commitment in March this year when we started the pandemic that we would meet with the public every Monday when we weren't even every Monday, including our regular city council meeting, and address the pandemic and the issues in our community and bring the community up to date. Today, we're doing a special workshop with the Oklahoma County Health Department. Many people think that the city of Edmond has our own health department. We do not. We have an emergency management operations at our city. Matt Stillwell. Matt, raise your hand. Matt Stillwell is our director for the emergency management, but we rely on the county offices, the county health department to provide expertise and information to us concerning how we are doing in our community and how cases are spreading and what actions we might need to take to protect our community. This week, the University of Central Oklahoma, the students are going back to college. One of our council members is back at work as he's a teacher at the university. And we're going to also have our schools this week also starting back to school, our grade schools, our public schools. And so there's a lot of things that are happening in our community. And it's very important, I think, that all of us be supportive of the parents and the teachers and our school system as much as we can. And part of what we want to do is to make sure that they understand we're doing everything we can to keep our community and our schools and our university and the students and teachers there safe. Okay. I'd like to start with the introduction of our panel and our council members. David, can you start with you and tell us where you're broadcasting from today?
Sure. David Chapman, I'm the Ward 1 Edmond City Councilman, and I am in Ward 1 at the University of Central Oklahoma campus in the College of Business.
Thank you. Josh?
Josh Moore, Ward 2, Edmond City Council, and I'm at my house in East Edmond.
Okay. Daryl?
Daryl Davis, Ward 3. I'm at my house on the west side of town in Ward 3.
Thank you very much. Nick?
Nick Massey, Ward 4. I'm in my office in Edmond.
Somebody's working here too, in addition to David now. Okay. Thank you, Nick, for being here. From the city, we have our city manager, Larry.
Larry Stevens, city manager, and I'm in my office in the City First building.
Okay. And Matt?
Good afternoon, Matt Stillwell, and I'm in my office in the Public Safety Center downtown.
And Mr. Murdoch, would you introduce yourself and the lady next to you?
Mr. Mayor, we're still having issues. With
Mr. Steve Murdoch, our city attorney there, and our city clerk, Cinda Cavell. You all can wave, okay, if you can hear me. Okay. Latoya, would you mind introducing, we have at the top right of your screen, I think, is the county health official in their conference room. Latoya Knighton is the administrator for them. Would you introduce yourself, Latoya, and tell you who's at your table there?
Sure. Again, Latoya Knighton, Government Affairs here at OCCHD. And then we have our Executive Director to my right. Dr. Patrick McGough, or Dr. Mack, as he prefers to be called. And then to my left, Phil Maytubby, our Chief Operating Officer. We thank you all so much for the opportunity to be on this call.
Well, we want to thank you for making time for us on this and all of your advice and assistance, the meetings, and letting us participate. In addition to Oklahoma City, who's probably your number one client sometimes, you have how many cities in Oklahoma County that you deal with besides Edmond and Oklahoma City? About 5 others, isn't there?
More than that, closer to 12 or 13.
14.
Yeah, 14 or so.
14.
And Mayor O'Neill, I also failed to mention Blaine Bolding, our Chief of Emergency Preparedness. He is also dialed into the line, although he's not in the room with us as well.
Okay, well, we're glad to have him on board too. First thing I'd like to do, if I could, is just we always start our meeting with a quick briefing from our city manager, giving us an update on things that are happening. Things are pretty quiet in town, Larry?
Yeah, not a lot of changes, Mr. Mayor, members of the council, since a week ago. Just a reminder that our goal has been the same since day one, and we started to address the pandemic, and that is to continue to provide services while minimizing exposure to the public and to our employees. That hasn't changed. We now have 5 employees who have tested positive for the COVID-19, and that's out of almost 800 full-time employees. We are requiring masks for all of our employees and anyone who enters one of our 30-plus city facilities. We also, all of us wear masks, and we require masks to be worn whenever we leave our individual office areas, even in our same building. So I think that has worked fairly well for us as well. So, and with that, I'd be happy to answer any questions, Mayor. Not a lot new in the last week.
Any questions, council, for the city manager?
No.
Okay, thank you. Matt, can you give us a brief update on what happened recently in terms of our new cases?
Sure, absolutely. And I'll leave the bulk of the stats to the health department. I know that they're prepared to share a lot of trends and overall stuff, but specifically for Edmond proper, we are now up to 835 cases. For the past 14 days, we've averaged just over 10 cases per day. And if you recall, at our meeting 2 weeks ago, we looked at the previous 2 weeks and we were over 15. So we're certainly seeing things trend more in a positive light and the direction we want to go. But like I said, my colleagues here at the health department, I think are going to go more in depth on that. And before I hand it off, I do want to recognize the strong partnership that we have with the Oklahoma City County Health Department. It's far beyond the COVID crisis. We've been working arm in arm with them in all kinds of responses for a long time, long before I ever came here. And just one example of how we've partnered. We had a tornado come through Oak Tree, if you remember. I think last time you were mayor, and the health department showed up, and they were ensuring that all the public safety responders up there had their tetanus shots up to date and everything. So what they do is really far-reaching. The relationship that we have with them goes far beyond what we're dealing with in COVID. But I did want to recognize how strong that relationship is and how much we rely on them and their expertise. And we're very, very appreciative for all that they do.
Thank you very much. Well said, Matt. Okay, Dr. McGuff, Dr. Mack, it's time for you all to put your slides on there and dazzle us with the information.
Well, I'm going to let Phil and LT do a lot of dazzling. I'm not in that department, but we really do appreciate you guys having us on, and it's been a pleasure getting to meet you, Mayor, even though all of it's been virtual, over the phone, or over email. But I do want you to know I went to a personal appointment with a cardiologist recently, and there was a delightful woman there that just told me over and over how amazing that you were. And I said, well, I'm getting to know him, and he is quite the guy, and we appreciate him too, but you definitely have your fans.
Well, there's a few Dan fans out there, yes.
So, Phil, dazzle them away and I'll help you.
You want to start the slides now?
Yeah. Okay.
Andy.
That's your
Andy?
signal.
That's the signal.
Andy's bringing them up.
Okay. Thank you, Casey.
Well, this is our confirmed cases right now. You know, we have 11,715 here in Oklahoma County with 132 deaths. Just to keep that in perspective, Oklahoma County has 23% of the state's population. So we're right in line with our populational expectations. The state of Oklahoma is just almost right at 50,000 now. And on the death side of this, we are starting to trend up again in the over 65, but there's a difference in now and when we first started. Now, the majority are not long-term care related. So that's a little bit concerning. So next slide, please. This is our syndromic for ILI. This is one of the indicators, and this is very different than case rates. This is out of chief complaint data that comes directly out of the emergency rooms. So when somebody shows up for the emergency room visit, this is what they're listing. They're either listing symptomology that's consistent with COVID or with influenza-like illness. Next slide, please. Same here. The first was ILI. This is COVID. As you can see, they're fairly high. Anybody have any questions about that, or you want to move forward? Let's
So
go
I
ahead
do
and move
have a
forward.
question. Is
Go ahead.
that real-time data, or is it delayed by any aspect, any period of time?
Oh, this is real time. This comes directly, it's reported directly from the hospital to us. So it's not going to be like some of our case data and things that we really should be delaying by 4 or 5 days.
Okay, thank you.
You're welcome.
Doctor, these are people that visited the emergency room?
Yes. So what the first one too, I think it is kind of just boils down. Bill does it so much, and he's so used to all these terms. But that's the first one: is people going to the emergency room that have flu symptoms, flu-like symptoms. Or this one that we're looking at right now is COVID symptoms. But that's all it. When they're calling, the first one was the ILI, and that was the one I was talking about, the flu. And this one is COVID. And that's correct.
Does this tell us whether they were admitted to the hospital or whether it was confirmed that it was COVID?
This does not. This, sir.
That'll actually show in the hospitalization data.
Yeah, we'll see those in just a minute.
So go ahead and switch. All right, here we go. This is our daily new case count. As you can see, we were on an upward trajectory, but it looks like we're starting to trend down a little bit, which is good. We hope this stays this way. The mask ordinances are definitely having an effect. And I think everybody that's out there now is already kind of proving that is the case. So even though we are trending down, if you will look at the numbers where we're at now, and where we were back when this started, we're still significantly higher than then. We're just situated better to handle it now. We have more capacity. Any questions on that one?
What does that mean by more capacity?
Well, for hospitalization specifically, there's more rooms available. There's more staffing. It really boils down to those two elements on the hospitalizations. So we'll talk about that here in just a second. If you want to go ahead and roll to the next slide, please. That's just a metro slide. All that's doing is adding in the parts of Oklahoma City that are in Cleveland and Canadian County. And as you can see, it doesn't change it drastically. So you can go ahead and go to the next slide.
So let's go back to that one a little bit.
Go ahead.
Your information on Oklahoma City and as of Cleveland County, is that coming from them, Cleveland County, or is that coming to you direct?
This comes directly out of the acute disease database. So, yeah, it's not from them. And so that's also why there's a delay on it, was that, Mayor. There's a delay on that one because of the delayed in reporting that we get from the Oklahoma State Department of Health. So the best that we can give you regarding what the gentleman asked earlier about was this real time. So this one is the one that shows a delay, but where it goes through 8/11, that part is done. That data is complete, so we're not worried about it being inaccurate or needing to be filled in. And I think that's what he was referring to. So what we get from OSDH, sometimes we'll get several days of backlog data. What we get from hospitals, it comes out that day based on a report the hospital provides directly to us.
Thank you.
So, yeah, and you're going to see that. You've probably already seen that on some of our slides and our graphs where we have the last few days grayed out because we know they're going to backfill. So you're going to see that moving forward. I mean, as far as accuracy, we really need to go back about 4 or 5 days at that point. And all of these reflect that, Phil. The ones that we've pulled for this, it's already done. Yeah, it's already done. So these are accurate up to this point. You just don't see the last few days. Next slide, please. Same one.
Doesn't it seem like that the trend lines for the last 2.5 months have been sort of stable or trending down?
Well, we were slightly trending up, and then we plateaued for a little while, and now it looks like we're starting to trend down just a little bit. So, but that's a very recent phenomenon. So if you take, for example, Mayor, the one that Phil currently has up there, that one just runs from June 4th till August the 11th. And so collectively across the page, that red line being the trend line, it shows it's going up. But if you just took the 2 weeks out of the middle, it would show what you're talking about. It plateaued for a little while, and then now we're seeing a drop. And what we're hoping on that, the right side of your chart, is that drop this time is not, it's dropped further and it's staying down longer and it's not coming back up as high. We're thinking that is early signs of the ordinance that we put in place in Oklahoma City.
So that low number of 87 that looks like it was on July 18th.
18th, correct.
And then another 7 days, and then another 7 days. It seems like it happens about 4 times in a row.
Yeah,
is that a weekend day?
That's exactly right. Yeah, we got it. We get bad reporting on Sundays, and just to tell you that. Okay. Well, there's less business in general, less testing. Correct. So any more questions, or would you like to move forward? Let's go ahead and switch. Positivity rate. So I think you guys have heard a lot of discussion about positivity rate being one of the indicators that we need to use moving forward. So this is our positivity rate for Oklahoma County. And as you can see, it's still way over where we want it to be, especially for schools. But, we're dealing with it, and hopefully it's going to start coming down. I think it's already started trending down just a little bit. But I'll just tell you, our current positivity rate is that we're getting through our sites is over 14%. So that's not, you need to know that as we move forward. Yeah, and I think what's important about that, so when Phil says at our site, so if we're providing the testing ourselves, those are coming out about 14% with our locations. But, we get the results for the entire county, so whether it's a hospital or a private physician's office or someone else, all that gets factored in, and that's where you see the 19.3, I think, on the last bar for August 9th. So that's the positivity rate there. So realize also this is heavily affected by pre-surgery testing and things of that nature. It seems like the majority of the people that come to our sites for testing either have been exposed or they're symptomatic, or, I mean, we're just getting a higher percentage rate coming to our sites. Next slide, please. Go
The
ahead.
percentage of people that are asymptomatic, has that been increasing? I would think.
You know, I've got to check on that. I'm pretty sure we've been trying to capture that. I know it's going to be the case because the highest percentage of cases that we have now are in the 15 to 24 age group. That's changed drastically. You know, when we first started this, it was in the 65 and over, and then it moved down into the 50 and above, and now it's down into the 15 and 24 degree or age group. So we know there's going to be more asymptomatic cases going on.
And it is a correct assumption that if you're asymptomatic, that you no longer have the symptoms, but you've had the illness at one point in time?
Well, I think the key there is if you're asymptomatic, you don't even know it, especially when you are able to transmit the virus. So we get that both in asymptomatic and pre-symptomatic. So pre-symptomatic is the 2 days before you actually exhibit symptoms. This is why masking is so important. Masking takes care of most of these issues. So to clarify that, what Phil is saying is some people have it and they would actually test negative if they test too soon in the infection. And so also, especially if they're asymptomatic. So if they don't have a mask on, and then there's about 4 days where they're at the peak of infection, where they're more infectious to others. And that's why it's real pivotal that people wear masks when they don't know whether they're sick or not, because sometimes at their most infectious point, they've just started showing any kind of symptoms. Kind of like we heard about an individual that just said that they felt, well, I didn't feel well, but I wasn't that sick. And that was the early part of it. And then you have a person get exposed to someone like that doesn't realize they're sick, not wearing a mask because this person wasn't, and they were at work and exposed a lot of people unnecessarily. And if they had just had a mask on, it would have been several reductions of spread of the infection. So that's why we're just constantly, talking about masking is just to prevent the droplets spreading when people don't even realize they're infectious. Hey, another key point on this slide, you see where we're at. Where we're trying to get is 1.4 or below. So we still have, even though we're having some success with the mask ordinances, we still have some work to do. Yeah, and we understand, Mayor Holt and I were on the phone with Dr. Burks a few weeks back, and she made the news this weekend. She was back in Tulsa, and she even said, even if we could get it down +3 of that, right, Phil? So the goal was 1.4, and then she said you could add 3 or so to it. We're still so far from 4.4 or 5. Say if they wanted it to be 5. We are just so far from that goal. It seems insurmountable. We've got some work to catch up on.
Does the positivity rate have anything to do with the different types of tests that are out there?
Not really. Positivity rate, it's independent upon rate. It's just the different testing methodologies that are there. Right now, every result you see there is from an RT-PCR test. So at some point, you may see us start talking about some antigen testing, but no. Right now, it's not affecting it.
Okay.
Yeah, I think, Phil, they need to know the difference between RT-PCR and antigens. I'm sorry, I'm a science geek, so I'll make sure I explain these. So the RT-PCR test is the one that we use as a confirmatory test to make sure you actively have the virus. So that's the one that we use to confirm you, to say, all right, now we know you're really sick and you're going to have to isolate or quarantine. There's a new type of test that's out there. It's an antigen test. It picks up the antigens on the actual virus. So it does tell you whether or not you're actively ill, but we can't use it as a confirmatory test because the sensitivity is not as good as what it is on a PCR test. Did that make sense to everybody?
So what's happening if somebody gets the rapid test? What are they doing next?
So I'll just tell you, the rapid test, you know, they got a bad rap at first, and that was they were using some wrong reagents and some other things like that. The rapid test now has really picked up on the sensitivity and the selectivity, so they're accurate now. So when the rapid test that you're seeing, like from some of the medical clinics and things, that is a PCR test.
Good.
So,
and is that counting as a positive or a probable?
No, that's a positive. An antigen positive with symptoms would be a probable.
Okay.
So what's your expectation now that we're back and we're doing thousands and thousands in Norman and thousands in Stillwater, and possibly even here, we're doing free tests now here on UCO's campus as well. So that should help to bring this down a little bit as we get more tests. You would think that these are not people that are symptomatic. And so you would think that it would help bring this down a little bit, right?
Well, we really just don't know yet, because when you add thousands of people together in any scenario, you know, there's a far greater likelihood of somebody being able to spread it to somebody else. So we just don't know. But to his point, what he's asking, and I think, of course, you understand that, but like the more that you test, and you're testing people that are not positive, you're going to drive down your positivity rate. He's correct. But so that's right. It's just right now, so far, it's not been very successful where we've had large groups, like the colleges are testing a lot of people. And so then we're, of course, getting some positives. And it was kind of like when we first ramped up testing and you were finally able to test people. We saw one time when the hospitals returned to doing elective surgeries, positivity rates took a dip for a little while because so many people were getting tested. I think you remember that, Phil. But that's not what's happening right now. But I hope you're right. We hope you're right. So, yes, we will know very quickly as soon as everybody tests. Next slide, please. Same, just with the metro. I don't know that there's a great significant difference there. Here we go, death count. So this is what I was talking about a while ago. Our death counts, I mean, they're starting to pick back up again, primarily in the over 65 age group, but not in a long-term care center. That's a bit concerning, because what that means, so they're getting exposed somewhere. And, you know, in a long-term care center, they're basically locked down. I mean, they don't allow visitors in most cases, and when they do, it's highly supervised with distance and a lot of times outside. So what this tells me, and this is something that we suspected would happen, is as you get more positivity in your population as a whole, the availability of people to be exposed by others unknowingly increases. Yeah. So, you know, this is a little bit concerning to us because especially with school starting up and so many grandparents watching kids, you know, we're hoping that nothing happens, but the potential exists and it's there. Well, and I think even too, we're seeing with that young adult, you know, older teenagers, young adult group, a lot of those folks have grandparents that are in this new age, this death group. And what we understand already is that young people can run around, expose themselves to one another, have mild to no symptoms, get over it, but they're exposing maybe a grandparent that they live with or one that they visited. So not the ones that are in the nursing home or a long-term care facility. And that's where that has switched over. And it's no longer just people that are in a care facility being exposed to one another or by staff or something like that. Now it's literally probably a lot of this, it has to do with these folks getting it from their own families and small gatherings and stuff. It's just, we're still looking into the details and the specifics on that. And we do know, some details that we do share with the public when we can, that's, kind of drills down into some more granular level. But our goal in that is not really to pick on any entity or any certain thing. It's just kind of to make people aware so they can take care of themselves. And I'm just suspecting that this now is looking like Phil said, it's grandparents. And because a lot of people at that age that are passing away, they're retired, but they're certainly not in a nursing home. And so they're getting it somewhere. And that age group seems to be a lot safer and not running around as much. So.
Any further questions on that?
Yeah, so how do you, one of the things I keep asking questions about terminology, and correct me if I'm wrong, on your website, do you have a thesaurus for all the different terms that you're using?
That's a good idea. That is a great idea.
Okay, because one of the other questions I have is, how is it defined that this is a COVID death or a death that was attributed to COVID?
Yeah. Okay, that's either from the medical examiner or if they tested positive while they were in the hospital and then died.
Okay.
So for the people who are just found, this is actually a case, something we were working on with the EMs, the emergency managers very early. Is like if you found somebody unresponsive, there for a while they didn't even have enough tests to test the unresponsive people to see if it was COVID related or not. So they have the ability to do that now. But a large majority of the deaths related to COVID are hospitalized, so they are tested for that in the hospital.
And then it's going to depend on what someone puts down as the cause of death.
Right. Yeah.
Yeah. So that's that.
And there's usually a comorbidity involved. So, but right now, I guess regardless of whether or not it was the heart attack that killed you or the diabetes that killed you, if you tested positive for COVID, it's probably going to be listed as a COVID death.
Guys, how is this chart comparing with Tulsa?
And that looks about the same.
Probably pretty close.
It's our serious series is different, but it looks very similar.
We mirror each other on a lot of things, and in that category, we're probably very similar. We pretty much go head to head with them on deaths, so it's probably going to be very similar. I would have to pull it up exactly to compare the two.
Yeah.
Well, it seems to we are showing quite a few more days of 0 deaths here recently. And if you were to look at that, it's a relatively small number on the deaths chart. But,
yeah.
It seems like there is some stabilization shows with the number.
There is. The only problem is it's stabilizing at a higher rate. This is the reason that we show this chart specifically, because this goes back all the way to March. So hopefully this is not our new normal. We're trying to make sure that this gets back down to what it looked like a couple of months ago, where it's definitely more manageable for everybody.
But will we say that the death rate count, whenever that does come in, that is in the arrears, that it's not from yesterday, it could be from sometime in the past?
It can be, because some of those, especially the one that come out of the
You're talking about the OSCH FIDO or?
No, the medical examiners. Sometimes
we get them days late.
Sometimes those are delayed, and then sometimes there's delayed reporting also through the Oklahoma State Department of Health vital statistics.
But it's about 5 days. So usually if you're looking at something right, it's about 5 days or prior, they've completed that.
It should be, unless there was just some
significant lag.
Yeah. Testing results. So.
Okay.
And that's another reason why we go back a few days, just to make sure that we've given time for things to catch up.
On this one that they're looking at on Oklahoma County daily deaths, though, Phil, back to that one, that it shows through the 16th, and that's
Right.
it's
So that
probably
was-
not correct because
maybe not.
today's the 17th. So that's
Oh, no, I can almost guarantee you that.
So we've had about 17 more deaths in Tulsa County.
Okay.
total.
So we're running a little higher. I don't know if you heard what LT said. We have had 17 more deaths than Tulsa County.
But generally, over time, about
But if you think about it, we have 100,000 more in population. So that, I may explain that.
Which one is, okay, so I think you could go, you could.
All right, ready?
move
Next slide,
forward.
please.
This is your hospitalizations.
Yes, and that one is for Oklahoma County only, is the one that you're looking at. So that kind of shows along back in March, like Phil was talking about, we thought it was a big deal then, and then we really had that giant surge, that started about, I guess, June 15th or 17th or so. But we are hoping that when you see this one dropping in the last couple of weeks on the end of the chart, because that is hospitalization data, that is current through today or through the whatever date it says, like the 14th, that's actually complete. And so that is showing that not only did it stabilize and now it's dropped, and it looks like it's trying to come to a new lower normal, a new plateau. And so we're hoping that that part is reflective of the mask ordinance again.
Yes, typically our hospitalizations run about 2 weeks behind case finding. So that may explain some of this, and it's exactly what Patrick talked about here just a second ago. It's that masking ordinance coming into place. So it's going to take, we knew it was going to take 2 to 3 weeks for us to see the outcomes of that, but that's what we're seeing now.
One of the things that I heard was very promising was the fact that the amount of time in the hospitals had been reduced from 11 days to 5 days. Is that still the current trend?
Yeah.
That's correct.
Yeah, and that's because they have, this was novel. It's still novel, considered a novel virus. It's new. And early on, hospitals and doctors were just having to scramble to figure out what you do. And I don't know if many of you know the CEO of Integris, but, he talks about how much they've changed their treatment modalities from the beginning of this COVID response till present. And I know personally, I had a brother-in-law that was older than 65 recently in the hospital at OU Med, and he actually ended up having to go to ICU, and that's usually a really bad sign. And he was in and out of there in less than 10 days, and that had been a lot longer hospitalization prior to that. And then now I hear it's shortened further. So that is true. I can speak to that as a family member. I know that's happening.
Hey, another key point to remember here, if we had had the current hospitalization rates now that we have back in March, our death counts would have been horrendous.
Yeah.
So the deal, we're dealing with younger people being in the hospital, and it's creating better outcomes. Plus what Patrick just brought up with better treatments. So.
And looking at this current ICU hospitalizations, and the reason that, this is on the ICU, they're so severe. So you can see people, Phil's talking about an age group, they come in and out of the hospital, but if they make it to ICU, if they're that severe, that's still looking pretty stabilized at a higher rate. I think you'd have to turn.
Yeah, you want to go ahead
one
and change slides, please?
Yeah, see the end of that looks more plateaued and it hasn't really gone down. It just keeps repeating the cycle over and over at that new plateau. And that's just the severity of the case. For them to be in ICU, they're not really seeing a lot of difference, but the hospitalizations are briefer, definitely.
And our ICU hospitalizations, that as far as the capacity that's there, it bounces anywhere from around 4% to 15 to 16%. That's dependent not only on beds, but on staffing for the ICU rooms. So it's a little bit of a moving target, but not.
Yeah, it's not very, in some ways, when they talk about capacity or ability to manage or have surge, it's kind of a lot up to the hospitals because they get to decide if they make a new wing into a COVID wing or not, or if they declare a new area is an ICU area or not. So surge beds and capacity are less important to us than just the total number of hospitalizations or the total number of people in ICU, because that speaks more to the severity of the case.
Okay. Any further questions on that slide?
So I have a question about, one of my concerns is that the masks were going to help, and they did, but it seems like that will plateau and that they're only going to help a certain amount. And then we need something else to help beyond the mask. Or do you anticipate that they're going to continue to provide relief and get better and better?
And that's a brilliant question. We do anticipate, this is the early, signs that it's making a difference. It takes a while before you see it. I think Dr. Burke said it takes 2 weeks. I don't know if it's that quickly or not, but I guess we were seeing that maybe as soon as 2 weeks after the ordinance. But our hope, and what we've seen some record of in other, cities and other areas, they're kind of going by that. It will continue to decline. But what you're saying is very true. If we don't at least get it down somewhere where it's manageable and we can allow people to go out in public with the mask on, we would have to implement something else. I mean, I think that's what we'd be looking at.
Well, a vaccine.
And that would be, that would be a vaccine, which, everybody's heard. It may not be out until next August or whatever, but there's not a lot left to do if we don't go back into things that are just extreme, like sheltering at home and closing businesses, and no one wants to do that. And that's been our goal, is to try to keep things open and safe at the same time. And that's because we know that economy equals health as well. Because if people can't afford to go to the doctor and they can't eat well and they're not, doing things that are stimulating their minds and their physical health, that's going to decrease. And so we get that. And that's why I think we're more adamant about the mask at work and at school and different places, because if we can decrease it where we can manage it, that's the goal. But that is a concern of ours too. If it doesn't go down, then what?
Mm-hmm. And we need more compliance on the masking laws, to be honest.
They're not like the one even that we have in Oklahoma City. I'm so thankful for it, but there's so many exemptions. It makes it complicated. And then when one county does it, but the neighboring county, they have businesses across the street from one another, it really decreases the effectiveness. That's why it would really be helpful if we did it statewide, but that's I don't have any control over that.
All right, next slide, please. Same, just Metro. When we say Metro, that's adding Norman hospitals in. So that's the difference in those slides. Really not much else to talk about there. Same, and yes, you can tell it's almost identical to the Oklahoma County one. Let's go ahead and there you go. So this is the positivity map for the color-coded OSDH map, showing the positivity rates in each one. And as you can see, we're in Orange County, and it has our positivity rate there. It's 14.86.
I think it's 9.6.
9.6.
You're getting old. I forgive you.
Well, that's pretty small. So, you're going to see more and more orange counties on there. It's just the way this is going to go. We started in the metro areas where the population density was the highest, but as this progresses, you're going to see more and more rural counties pop up orange.
So Phil, do you want to talk about what that means, what the counties should understand what the code means for them? Unknown caller.
Oh my gosh.
Phil, your phone is out of control.
It is. It won't even turn off. Sorry.
Do you want to talk about what counselors should understand those colors should mean for them in terms of?
Sure, those are risk categories. So like right now, if you look at Oklahoma County, we're in the orange risk category. So I'm sure you guys have all seen the moderate risk phase guidance that's come out from the state health department. So what that means right now is these are things that are recommendations, and I want to stress that, they're recommendations from the state health department. So considering wearing face coverings in public, limiting out-of-state travel, washing hands often, maintaining 6-foot distance, not touching your face, staying at home if you're sick, symptom checks, avoiding large or public gatherings unless you just can't, providing meeting schedules to encourage smaller gatherings. And then there's some guidance in here for businesses. And if you go to the back, there's special items there for high-risk individuals. And really none of these they're not anything new. They're things that we implemented in one phase or another, like phase 1 or phase 2 or phase 3, as we reopened in the gating criteria. So I figured there would be a lot of questions on how to interpret this. So if you guys want to ask questions, go ahead.
There are no red counties, right?
Well, if it was going to be a red county, it'll probably be us or Tulsa. Yeah.
I mean, there is a criteria for red. No county in the state met that, right?
Right, and this is an Oklahoma State Health Department document. It's which we work with them, and we certainly, this is helpful information, but those documents are not ours. So that one, according to what they're saying and what's out there right now, yes, you are correct, Mayor. There are no red counties on this chart that they've provided today.
And even with the guidance that they have out there, it's not greatly different from orange to red counties to begin with.
So does this map take into the people that are said to be recovered?
That's really not factored into this map. This is just the positivity rate that we're getting out of current testing. So,
Okay.
we probably get about 1,000 or maybe a little more tests that are conducted in Oklahoma County each day. So this is the rate that comes out of that.
So it's more of a daily, it's daily, not factored in with everybody that's recovered versus everybody that currently has it. It's not that.
Okay. In the presentation today, are we going to discuss, do you have a chart that addresses recovery?
Well, we have recovered. I don't know that we have the recovered numbers on there.
But we can send that to
get it. Yeah, we can get it for you.
Well, the question is, it goes back to my terminology again. I don't understand what recovered means because I've seen people that said that the numbers, they've dropped off they said they were recovered, but they still have some symptoms that ebb and flow with them. And so my simple termination is they're not recovered. So.
Well, I think what the terminology you're looking at is recovered actively from the virus. So that doesn't mean there can't be lingering effects, and there are for a lot of people.
Right.
But they can't actively transmit the disease anymore.
Yeah, and those are kind of, again, that's getting into the state model they use. I think the governor asked specifically through the task force, they look at what they call recovered, which are people that have had it and that are over it. But as Phil pointed out, and someone on the call, I think, pointed out, I mean, this residual, because it's a new virus, is unknown. There's early studies showing that even young people may end up having neurological leftover symptoms, cardiac, even fertility issues related to this. And it's because of the inflammatory response of the body. And then you've probably all read that there's a lot of studies already being done on what it does to a cardiovascular system, and it increases like the clotting factors and things like that. And so people are getting all kinds of other issues. And of course, it's too soon to really know what are the long-term effects on our young people, but That's the thing that they kind of need to be focused on. We know the death rate is lower for them, but what we don't know is what are the long-term side effects of this virus, because it seems like there's going to be some and that they're pretty severe. So I can tell you how that's done right now. It's 10 days after active symptoms or 14 days after asymptomatic test results. So it's pretty much done on time at this point.
Okay, very good. Thank you.
On your positivity charts there, if a person tests positive with COVID, would any other virus cause that same positive test?
No, as far as co-infections, we're not getting anything. There's no interference at this point on a COVID test.
So,
Guys, what's in the water in Beaver County?
That's called no people.
I think it's called population density or the lack thereof.
They're doing pretty good.
Yeah, they're doing great. If you remember, though, somewhere out there in the Panhandle, which I won't mention, there was a little issue for a while with an outbreak that made the news that wasn't so good.
Next county over.
I was not going to say that. So they must have that underhand, and that's good. I know, so my home county originally, I was from McCurtain County, and they're improving now, but you guys probably saw in the news a few weeks ago, we weren't doing so well down there. I mean, it was bad.
Hey, and a lot of these other orange counties, there's usually been something specific that's kind of gotten them there, like a poultry processing plant or a jail outbreak or something of that nature.
Or long-term care facilities.
Long-term care facilities, yeah.
So we have about 10 minutes.
Okay.
Okay, we need to let them.
We're asked questions.
Sure. You guys have questions about schools?
we certainly do. I think this our pattern that we've chosen seems to be a good way of sliding into school and getting kids back to school and comfortable with the process. We worry about the ability of parents to figure out their own schedules on how they continue their jobs if they have to work at home, work some other place other than home. Do you have any record? You've been working with the school. Obviously, you talked to the state school Department of Education today. What are their concerns that we might share with the community?
Well, they're the same as the ones you have already. I mean, if you're going to have to do distance learning, how do we treat the kids? Who's going to watch the kids, especially if there's two parents and they both have to work? So, I mean, those are significant issues. Plus, we have issues, or everybody's worried about, okay, what if we start school up and now all of a sudden we've got half of our schools down because of positive cases in the school? Everybody's concerned about that. Plus, if you think about it, most of your bus drivers are high risk. A lot of your teachers are high risk. You know, here the biggest issue is not the kids themselves. It's that the kids are probably going to expose the people that can't afford to be exposed. So, you know, everybody's trying to figure out ways of doing testing and monitoring their own people.
And so, Mayor, one of the other meetings we had today, and we've actually been working with most of the school districts in the county for some time, going back into the middle of summer. But today we held a countywide Zoom call where about 37 to 40 people called in from different school districts, primarily focused on the schools that are having in-person classes, such as, I know, Edmond, you all are doing an A-B schedule, I believe, and so you will have some in-person learning. And so working with those schools to help them dive into some of the guidance that we can provide. We've created some decision trees so that schools understand the appropriate actions to take if, for instance, there appears to be student-to-student possible exposure or adult-to-adult possible exposure, for instance, a teacher to another teacher, or a staff member to another staff member. And so we are working directly with the Edmond Public School District and all of the school districts across the county in understanding those processes. Once a positive case is identified, or if it's a suspected exposure, our epidemiologists immediately begin working with your school administration to begin contact tracing, tracking where that student has been, which classrooms, and of course, contact tracing like we would with any other situation. We also, of course, Phil and his team, they are available to provide guidance around activities. A lot of the schools have questions around, should we be doing choir? Should we be having, we're planning indoor sports or indoor drama classes and the like. And so we're talking through all of those questions with the individual school districts. And as you can imagine, every school district is different because each school district, of course, is approaching this differently. But we're certainly available to them and have identified a team within the agency that will be working and going directly into the school to help with those contact tracing investigations as well.
We've always had a little concern about one zip code, 73013, which is part of Edmond. It's about 40%, but nearly 80% or 70%, 75% of our death cases come from that one particular zip code. And we're not aware of anything particular on that. We have a total count, I think, of 22, and I think 15 are from that one zip code. And we have other zip codes, 3 that have none. And one of our biggest zip codes, 73034, was only 1. And so it just doesn't sort of match up what's going on with in 73014 or 73013, which is south of 15th Street. And it goes all the way to Memorial and all the way over to Pennsylvania. So I understand there were some nursing home issues in that area. Any other clarification that might have been a spike that caused that number to exaggerate?
That's actually it, and there's still issues. So some of your deaths are coming from that.
I have a question.
I appreciate it.
I have a question about the numbers here and how you use them on your chart. Oklahoma County is 11,715 cases, and I guess we've determined that 835 of those are in Edmond. So if somebody tests positive, they become a case. If they get better at some point in the future, do they drop off that number, or once you're a case, you're on there forever?
No, you drop off. Oh, well, no, the case number always is going to be there. And that comes back around to that recovered issue.
So that over time, that will just continue to grow and never shrink.
Correct.
Okay.
Yeah, that's the same thing for the state and for the United States on this front page.
Right.
That's the same all the way across. Yeah.
And you're a victim of your own success and your population on that. Because the bigger you are, the more cases you're going to have, and you're like the 5th biggest city in Oklahoma.
Hey guys, to piggyback on the zip code question, do you look at this as a metro effort or even bigger than that, a county effort?
Yeah, it's definitely a county effort, and it's always that. The metro piece gets added in because of the effect that it has on, neighboring pieces. I think Norman sometimes ends up, or information from that county ends up in our stuff because it butts up against another populated area in our county. So we look at all of it, actually. We kind of look at it as a state too, but we really, our primary focus is Oklahoma County, but you can't ever just look at one county in the middle of a state. It's just too much of what everybody else does has a significant bearing on us, especially when we're surrounded by other counties that are not city counties, but they're, you know, OSDH counties. So,
plus we have hundreds of thousands of people that come in and out of here every day at work. So, you know, we're a hub.
And then just before we have to end, could you just run down your recommendations just real quick on how we can keep this number down the best we can?
Start with masks.
yeah.
So number one, masks. So the mask thing is the thing that's going to work across all boundaries without any issues. It's going to be the most effective thing, and it's also going to be the most equitable thing. So I mean, you're not picking there on who gets to wear one or who not. I mean, you can put exemptions in there, but it's by far the most equitable to business if you can put a mask ordinance in. Because I'll just tell you, if the people ever lose faith in their ability to go out in public, you won't have to worry about closing anything. It'll close on its own. So we have to keep people, you know, safe in the fact that they think it's okay to go out and go eat or go shop or do whatever it is they need to do. But there's other things, but, you know, we hope the masking is the thing that works, because it's the one that doesn't become punitive for us to go and start working backwards like we did in the phases, like where you're closing specific parts of the industry. We really don't want to go there.
And so in the recommendations too, if we look back again to like White House recommendations and CDC recommendations, it is the most effective thing that they've seen in other cities that are already seeing a decline. You know, others have done what we're doing now. The surge is kind of hitting south. And so what's happening, and it's kind of like what happened also within our own state, you know, it was in the dense areas, and then after it had been here for a while, then it began to go out into the rural communities and the rural parts of our state. And so now they're dealing with it more than they were early on. Same thing's happening with us statewide. Other states that were more populous have already kind of been through where we're going now. And talking with Dr. Burks, she had told us originally, you know, the number one and the best thing that you can do and the best thing that they've seen results from was simply masking, and masking at all times, you know, when you're going anywhere out in public and you're going to be around other people, whether it's work or if people elected to keep churches open, schools open, it's still masking is the number one thing that you can do. Then it's all these, and then we're still doing the distancing. We're recommending washing the hands. We're washing and disinfecting the surfaces. But you know, there's a lot less to the surfaces than there simply is from the droplets. That's why the masking is so important. And then of course the hand washing and the distancing. I mean, that's it. Now, when you want to start looking at how you can decrease it in business areas, you can start looking at things like cutting your restaurants down and your bars down and your, your shopping centers and stuff. But when you do that, you're going to get, as you all know better than we do, you're going to get a lot of backlash, and people are not going to cooperate fully. And I think if everyone could focus just very strongly on let's just wear a mask to protect ourselves and others, and try to keep things open. And if we don't see that works, I think these other things that they have shown, what did show results, and we're certainly willing to recommend those things, but we know for you as a city council and for folks that are focused on economy, it's harder to do. But they were simply saying restaurants and bars were to be decreased or to be shut off at 10 o'clock at night. A lot of that is because the servers in restaurants and in bars are younger adults, and what they tend to do is they congregate after they get off work. And, you know, they all get off a shift and they go somewhere together. And so they're spreading it to one another more or as much as they would be. And I'm talking about in other, just across the board. So there's a lot of things that you could do, but overwhelmingly, the mask is number one. So
another part of that too is just the education around why we want you to wear one. You know, I think that would be highly impactful to all the students that are going to be up at starting up at UCO. You know, hey, it's not okay to wear this at class and then you go out to the bar later with your friends without it. People need to understand the concept and why we really are wanting people to wear masks.
And we've always pushed both. It's the masking and the distancing combined. You'll hear our state health department, other entities across the nation are talking about, when you can't be 6 feet apart, wear a mask. But there are droplets that spread further than 6 feet, and so we recommend both. And that's what we practice here at work, at our office. And for us to be, and our staff to be on the front line every day, we've been thankful so far. We've had minimal, and we've been dealing with it from the very beginning, and we've just had almost no one infected.
We had no workplace exposure.
And we've had no workplace exposures. So the ones that we've had have been people that got it somewhere outside of here. And I hope that doesn't change tomorrow, because our staff are getting weary. They're getting pretty worn down. But it's been very successful for us. And so just our business alone kind of shows that people can work together all day. The most that we take our mask off is like during a meeting like this, when people can't hear us sometimes. We will pull it down for clarity and put it right back on. But we're pretty much emphasizing mask.
One question or statement you made is about the frontline workers getting tired. Is anyone doing any analysis on them, on how they are doing, even though the numbers are maybe stabilizing a little bit? But those same frontline workers are day in, day out providing that care to the needy. Is anyone doing any analysis on them, on their health and their?
Yeah. So we do here, now we encourage it for everywhere. I am certain that the hospitals, I know the CEOs that I have talked to, it seems like they all have a plan for their nurses and their staff that are dealing with all of that on the front lines day after day. Our staff, we've tried to do several things, not just physically to protect them, but also for their mental and emotional well-being. Like we've doubled and tripled their abilities to go see someone at work and talk about all those things. So we have an EAP program that's very strong, and we've got 2 different kinds now, and they have twice the amount that we pay for them to go visit. We're trying to rotate their time off, make sure that they actually get a day off and things like that. So, but they are weary. We've been going at this for a long time.
Well, we really appreciate you all doing this. I'd like to mention something I saw in Tabors Hospital did me, and they had a chart that sort of stepped up the risky behavior, shall we say, and the things if you worry about risk to avoid going to the bars, for example. I thought that was a pretty good way of helping people. You start with the easy stuff. When you get used to it, then you'll learn a lot more about how to handle yourself in public and deal with the crowd issues when you get there. So,
yeah.
Hey, Dan, I wanted to bring up one other thing before we leave.
Sure.
So, before we have picked out specific things in the community that where people were, that we picked up in our contact tracing information. So that's spreading out. It's becoming fairly ubiquitous now. Before we would have different things like restaurants or bars or whatever it might be in there. It's really spreading out. We have I don't know how many different categories with like 6 or 8 or 10%. So it's really spreading out amongst the whole general population.
Yeah. So what we're seeing, instead of it, go ahead.
You used to have a top 5, now you're up to a top 10.
Yeah, I think our first thing was a serious 7, and then it kind of went back and forth, but it stayed around 5, 6, or 7. But now, to Phil's comment, it's so widespread, and there's so many categories. I don't know how much meaning that has, but it still does have meaning. But we're looking at that at a more granular level, and we're going to be talking about that this week. We're going to have a meeting with some expertise from OU, from their College of Public Health, and kind of talk to some of their epidemiologists and see what they're thinking. So we look forward to that.
Was sports and swimming pools part of your areas of concern?
The swimming pool thing never materialized. I think it's already been shown that, it doesn't spread well in pool water. So that really did not ever become a major concern for us.
Yeah, I think we had some cases, but it wasn't any more than just everyday life. You know, it wasn't ever a hot spot.
Sports, that's a different matter. Indoor basketball specifically. We actually contemplated coming and talking to you guys at one point, but it seems to have died down some because of some of the indoor basketball that was going on specifically in Edmond.
I remember y'all thinking about some concerns.
Yeah, I think some of that people mitigated, they took some of their own actions and it got better before somebody else had to bring it to the world's attention.
Any other questions, council, for the fine folks at the health department?
Just one quick question that someone had asked me to ask, and that is the subject of false positives on testing. I personally know of 3 people who had a positive test and then they later had a negative test. But if someone tests positive and they become a case and then later it's determined that they weren't positive, it's negative, does the number get corrected, or is that just another number on there?
Good question.
That's a good question because we know it's happened, but I've never asked the state epidemiologist or OSDH how that actually gets categorized.
Thank you.
I know if you test positive twice, it counts as 2 cases. So, we've had people test 4 or 5 times trying to get a negative test, and they keep testing positive because it picks up viral fragments because it's a DNA test.
And they're trying to probably having to get that to go back to work, like an employer was requiring it. Because I kept thinking, why are these people doing this? So.
I noticed in the state director goal that they wish to have private and public entities test people and have the test results back in 2 days. Anywhere close for that kind of turnaround yet?
Well, we are.
For us, we're there.
No, city county health department's there. We've been there a little while. And when we weren't, it had nothing to do with our capacity to do that. It was the lab we were waiting on, and then the results get funneled back through the state health department. And then by the time it got back to us, but that's greatly improved with some of our current lab.
Are you doing tests during the week too, as well as weekends?
We are doing tests during the week, but we just signed a contract with OU College of Nursing, and they're going to be providing test sites 7 days a week, including the evenings. So that'll be down at 10th and Lincoln. So you should see that. And there will be availability. I'll just tell you, demand is a little bit down right now. If you call, you can probably get a test the next day, and some days you might even get it the same day.
You said call. Is that still calling 211?
No, sir. That would be calling our number at 425-4489.
425?
4489.
Okay.
And then when we get all the contract worked out with the College of Nursing, we'll also provide you with the contact information for that one as well.
I think the University of Central Oklahoma has a school of nursing here up here too. Isn't that right, David?
Yeah.
Might be a good source to take this part of it and cover this part of the county.
Yeah, we had that. We had other schools of nursing think the same thing, and we did talk with them when they see what all it entails. Even if we're giving everything and basically paying for all of it, it's more than they feel like they can do. It's pretty extreme.
It takes about 3 partners to make it work. You have to have a testing partner, you have to have a swab supply partner, and then you manage the actual testing site. So
it's not easy.
No,
there's a lot to it.
Yeah, most of the nursing schools, it's all they can do to keep, with all the demands of college and what the dance they're having to do to keep it going. Then to add that is just kind of more than they can do. I think really, but not saying that UCO couldn't do it. They might could, and OCU might be able to do it. I don't know.
This is Blaine Bolding. Just to add on to that, we say OU College of Nursing, they're one partner. The other partner is OU Medicine, and that's the other piece of it. Because OU Medicine's providing all the PPE, some of the staff, but also that is their lab. They have their own lab. They can call back all their own results, and that's part of it. They're kind of an all-in-one. That's very unique for all the schools.
Yeah, and when they don't have that capacity and the nursing schools look at it, then they think, oh, there's no way we can pull all that off. Thank you, Blaine. That's good information.
Do we feel that our frontline workers have enough adequate supply of PPE for them?
Yes. Yes, we do, and testing capabilities too. We're still trying to hire tracers as kind of our focus right now. We're trying to bring on about 20 more. We just constantly add tracers, and so that's what we're looking for. And because everybody's looking for them, we're kind of having to rely on staffing companies and agencies, you know. It's a training that most professionals can do pretty quickly if they go through the training process.
Nurses is a different matter.
Yeah. Nurses, that's complicated altogether. I mean, everybody wants the nurses, and they're brilliant and very helpful through this process, and they're hard to find.
As they were before.
Yep. Yeah, this just emphasized it because everybody, you know, the big hospitals in Dallas are pulling nurses from our area, and it's really hurting because they're paying a lot.
All right. I want to thank you all very, very much for participating in the program and working with us on a day-to-day basis. I know I've attended a number of your Friday meetings, and Matt's probably on daily conferences with you all. We appreciate your service to our community and keeping us informed and trying to stay on top of something that 6 months ago we wouldn't have thought would be occupying our lives as much as this is.
That's true. Well, we appreciate all of you and your time, Mayor.
Appreciate that. Any other comments, Council?
Thank you, guys. Thank you very much.
Thank you.
Motion to
We
adjourn.
appreciate you guys.
We're adjourned. Thank you very much. Thanks again. Appreciate this so much. Bye-bye.